our Journals on Air podcast. I'm your host, Vicky Shamagam. I'm going to make a confession. I walk for exercise every day. I didn't always do this, but a few years back, I realized if I was going to preach the merits of exercise to my patients, I needed to manifest its merits for myself. And then I also realized that I needed to protect my knees because no one else would do it for me. So I was very excited to read the manuscript, Association Between Walking for Exercise and Symptomatic and Structural Progression in Individuals with Knee Osteoarthritis, data from the Osteoarthritis Initiative cohort, which was recently published in Arthritis and Rheumatology. A link to the article is in our show notes, and I'm thrilled to be joined today by the first author, Dr. Grace Lowe. Dr. Lowe is an associate professor of medicine, immunology, allergy, and rheumatology at Baylor College of Medicine in Houston, Texas. She's a physician scientist supported by a NIAMS K23 award, and this large study was part of the Osteoarthritis Initiative. Welcome to the show, Grace.
Thank you.
So I want to start by having you orient our listeners a little bit. Most of us have been taught as trainees that walking is good for osteoarthritis. It's in our ACR guidelines. But prior to this paper, the data to support walking as therapy in OA was relatively limited. I wondered if you could, forgive the pun, walk us through the previous studies of walking in osteoarthritis and tell us why you conducted this analysis.
So, yes, so there have been a few randomized controlled clinical trials looking at the benefit of walking, but it really only looked at walking on a short term basis. And it did show that people did derive benefit from walking in that they had less pain, but the outcomes were much shorter than what we're interested in for the study that we published that we're talking about today. So, what we wanted to do was to look at the benefit of walking on the order of years. So, do people derive benefit from walking, for several years? And so, within the Osteoarthritis Initiative, we had this opportunity to look at this question with very systematic evaluations of structural progression and of symptoms, meaning that we asked everybody the same questions and they had the same exams and radiologic imaging.
Yeah, and tell us a bit more about the Osteoarthritis Initiative because it's a pretty unique public private partnership funded in part by the NIH, in part by pharmaceutical companies, but really thoughtful and broad in its foresight because it looks longitudinally at patients with OA. It has a very well organized website where you can look at high level data from the study. And then as an investigator, you can apply to download de identified data for analysis. How did you get involved in the Osteoarthritis Initiative? And, what were the steps to getting access to the data?
Well, so I actually was quite lucky that I was involved pretty close to around the time that recruitment began for the Osteoarthritis Initiative, in that I worked with one of the PIs for the Osteoarthritis Initiative. And so that's not sort of the usual way that people get into the OAI. So the OAI is really meant for people who didn't necessarily have any in, to be honest. The idea was to provide this wealth of data that was very systematically acquired. And then anybody who had a question and we happened to get the data for it, they could just download the data as you suggested. And so my way of getting in was that I happen to know the PI, but the main way that people were planning for the OAI to be used was that anyone who had any kind of interest in osteoarthritis could just look at the data that's available and then figure out if they could use that information to answer their questions. So the way I got involved was that I put in a CDA, or not a CDA, sorry, a mentored award where I was funded by the NIH through a K23. And what I needed to do was to find a question that I could ask, but I needed to sort of do something new. So I added in the questionnaire looking at leisure physical activity within the Osteoarthritis Initiative. And so we asked people to reflect back on their life and tell us how they did multiple different activities, including walking, which is how we were able to ask the question that we asked in this study.
So it's interesting. I guess I'm going to come back to that questionnaire in a second. I'm going to start just by asking you a really simple question. you wanted originally to evaluate this relationship between walking for exercise and structural progression of osteoarthritis in people who already had baseline osteoarthritis. Um, can you help us just understand the selection of patients for this study? Because I think you included only people over the age of 50. Was that correct? And if so, why was that? Why was the age cutoff chosen?
So the age cutoff was partly chosen because the age cutoff for the osteoarthritis initiative started at 45. And so we couldn't include anybody younger than that. What we were looking for is prospective data. So the way that we rolled out the questionnaire required that people had to look back on their lives. And so the whole study was not just focused on this. So we had to ask the questions in a way that people could answer them irrespective of what their actual age was, right?
Got it.
So one of the questions focused on age 50 or greater, and so that was the way that we were able to look at walking.
Got it. That makes sense now.
Mhm.
And I guess you excluded a few subjects because they didn't complete the physical activity questionnaire or were seen during a time when that wasn't being administered. You had a few subjects that got excluded because of lack of x ray data. But in the final analysis, you had a lot of patients 1,212. Which included, I guess, 1,808 knees. So, just simple question. The missing knees were knees that had been replaced. Is that correct?
Oh, no, no, no. So these are knees that had radiographic evidence of osteoarthritis at the baseline visit when they were enrolled into the OAI. So everyone, when they got enrolled into the OAI, had a whole bunch of things done, including radiographs that were assessed. And so, based on the radiographs that they had at the time of enrollment, there was a group of people who read the radiographs for radiographic severity of osteoarthritis. So there's a scoring system which is called Kellgren and Lawrence grading, and anyone who has a Kellgren and Lawrence grade of 2 or greater was considered as having radiographic evidence of osteoarthritis. So those are the people who were entered, and the reason why it's 1808 knees and 12 people, most people just have one, or not most people, some people have just one knee that has radiographic evidence of OA, meaning that their other knee could be healthy. So it's not that everybody on their opposite knee had a total knee replacement. It's
Ah,
just
got it.
that we looked at only knees that had radiographic evidence of OA. In fact, if they already had a total knee replacement when they came in, that particular knee was no longer considered eligible for what we were looking
That makes more sense now.
at.
So thanks for thanks for clarifying that.
Sure,
So,
sure.
um, so you divided the group into people who were actively walking based on self-report versus those who were not. But can you tell us, I guess, first, did patients who enrolled in the osteoarthritis initiative receive any particular recommendations regarding exercise? And if so, did that include that they were recommended to walk, or were they just left to their own devices?
They were just left to their own devices. We did not give any specific recommendations. So the structure of the osteoarthritis initiative is not an intervention. It's meant to be just an observational study. So we did not provide any guidance to people with respect to what kind of activity that they needed to do. I would say this though, that we have to understand that the osteoarthritis initiative occurred in real time, and the CDC guidelines for physical activity did come out, I would say, maybe 2 years after enrollment to the study began. And so, in some ways, that has been recommended, right? So,
Hmm.
people did hear that, not specifically related to knee osteoarthritis, but as far as overall health, they were given recommendations to do physical activity. And one of the common recommendations is to walk. And so, from that perspective, there was this general public health message to walk. Yeah.
Yeah. Yeah. And in the group that you classified as walkers, there was a bit of a range of frequency with which they needed to be walking to be classified as a walker. Can you tell our listeners a bit about that specific group?
Oh, well, so we didn't want people to just count themselves as a walker if they just went for one walk. So we asked
Yes.
them to have at least some level of walking. And so they had to have done walking for exercise. Like we specifically wanted it to be an intentional thing, not just oh, I happened to walk at work for, because I had to deliver some mail or something like that. It had to be walking for exercise. And we required that people had to walk at least 10 times within that time frame in order for it to be considered that the person was an actual walker.
That's funny. So I used to have a phrase I would say to my patients: if you're walking and talking on the phone or typing on the phone, you're not walking fast enough.
That's right. I haven't actually seen a study where they they uh, test that sort of theory, but I think that's true, right? So when you're doing something else when you're walking, you're not actually you're not putting all your effort in doing it. So I think that that is true. So, but we were specifically asking about walking for exercise and not just the random amount of walking that they were doing.
Yeah. Okay. So tell us what you found in the analysis.
Well, so what we found that was the most exciting, I think, is that amongst people who had radiographic evidence of osteoarthritis but did not answer yes to the question that they had frequent knee pain at the time of inception of the study, what we found is that that group of people who were non-walkers had a 37% um, prevalence of developing new frequent knee pain by the time that they were seen in follow-up at 4 years, compared to people who were walkers, where only 26% of them actually saw that they developed new frequent knee pain. And so this meant that there was an 11% difference between these two groups, and that resulted in a odds ratio of zero point 0.6, meaning that there's a 40% decreased odds of having new frequent knee pain if you were a walker. So the idea is that prevention really might be the key here. In the past, we have not really pushed for people to get radiographs on people, particularly if they're not particularly symptomatic, because we always would say, well, what are we going to do about it? We don't
Right.
have any medications that are beneficial. And so, I think that the idea that prevention might be the key is really an important message, which we found in this study.
No, that's fabulous news, and at least on a personal level now, at least I feel like I'm doing something to
Yes.
help.
Yeah.
You actually found some really interesting differences, though, when you looked at the knee alignment at baseline and how people benefited based on their baseline knee alignment. Can you share those findings?
Sure. So before we go into that, I guess I would back up and say that the most important symptomatic finding that we found for the overall group was the difference in the new frequent knee pain that was developed. But what we also saw is that amongst people, the whole broad group who were included, that people who walked also had what seemed like less structural progression over time. And so because we know that osteoarthritis is a very biomechanically driven disease, it was interesting to us to look to see if people had a difference in their outcomes based on their structural alignment. So, varus alignment
Mhm.
being bow legged, neutral knees being pretty straight, and then valgus knees being knock kneed. What we found is that the group of people who had the varus knees, which is the largest group of people and knees included in our study, we really found that all of the findings were more robust in that particular group, meaning that their new frequent knee pain difference was very similar to the overall group, that the group of people who actually had a varus alignment, and we looked at structural progression, meaning worsening of the KL grade and worsening of the medial GSN score. What we actually found was that the people who walked did better than the people who didn't walk. And this is really surprising, I think, on some levels, because most of the loading within a knee actually occurs within the medial compartment. And so there was always a concern that if you walk, maybe that actually
Mhm.
makes your knees worse, because every time you take a step, you're putting more loading on that medial compartment. And so maybe that's going to cause a problem. But we actually found that people who have a varus alignment and are diseased in the medial compartment, they actually are the ones who benefited the most. And so that's
Yay.
really, yeah, it's really exciting. Um, so that's the biggest finding there. I don't want to put too much emphasis on the neutral and the valgus knees, because really we didn't have the same kind of numbers that we did as we did for the varus. But it is important to see that there was a difference when we looked based on static alignment. So I think going forward, when we're trying to recruit people for studies looking at walking, I do think it's important to understand what people's alignment is when we enroll them. So
Yeah, so
I
let
think
me
that
let me make sure that I'm understanding. So basically, we should probably be a bit more proactive at getting imaging at baseline, but all patients benefit from the walking intervention. It's just the biggest benefit are in the people with the varus alignment. Is that what you
well,
mean?
I guess I don't want to overstate our findings. I think this is the first observational study where we really know what the outcomes are in a very systematic way. And so we feel confident that what we see is probably meaningful. But when the numbers are small, particularly in the people with the valgus alignment, um, I guess I don't want to overstate what we can see or that what we can recommend based on that. I would say that there are some sort of concerning differences based on um, within that group of valgus alignment, where the people who walked actually seemed to do a little bit worse as
Ah,
far as their KL grade actually got a little bit worse. But this could also mean because this could also be because people who have valgus alignment tend to have more lateral compartment disease. And what we were really focusing on here was medial JSN worsening. So we didn't specifically look at lateral JSN worsening, but that could have been better. But, the study was not really primarily focused on, differences based on static alignment. But I did think that showing that there was a difference and that really the group who had varus alignment was the group who really did the best was very reassuring, because the overwhelming majority of people actually have varus alignment or neutral, and so it was really reassuring in that way. And strangely, the group of people who had varus alignment actually their structural benefit seemed better than those with neutral knees. So that was also a little surprising. So
yeah.
um,
Yeah, so jury's still out a little bit on some of those parts that are still some question on some of those issues. But the other thing that really struck me about your data was that you saw the biggest benefit from walking in this group of patients who were not having frequent knee pain. And so I kind of wonder, as rheumatologists, are we perhaps intervening too late, that by the time people come to see us because they're having osteoarthritis related pain in their knees, the impact of walking as an intervention is going to be um, possibly less beneficial. And if that's the case, do you think we should have a change of an approach and perhaps try to intervene earlier before people are kind of 50 or older, and certainly before people become symptomatic?
Absolutely. And I do think that this is potentially a paradigm shift as far as we don't do any kind of screening right now for osteoarthritis. And to be honest, it's kind of hard to diagnose people with osteoarthritis
Hmm.
without a radiograph. People have knee pain for lots of different reasons, and people don't necessarily talk to their physicians about OA, and not everybody gets to a rheumatologist, and even rheumatologists don't always uh, they're not really honed in on taking care of people with OA. I think that there's a lot of times this greater emphasis placed on our other patients who have inflammatory arthritides. And so, in some ways, osteoarthritis is kind of the black sheep of, of our diseases. And so I do think that there needs to be a different approach probably to people who have osteoarthritis, particularly because the prevalence of OA is so huge. It
Hmm.
really dwarfs all the other arthritides out there, but we're terrible at taking care of them. And so I think this sort of general paradigm shift really probably needs to be evaluated. I guess I don't know that we have enough data from our study to
Hmm.
recommend it broadly, but I think that that change in way of thinking really should be considered based on what we found here.
Yeah, yeah. I mean, I think it's really interesting. I wonder whether you'd be willing to talk about a few possible confounders in this study. Specifically, this question of whether people with less pain are perhaps the people who walk more because it's not so painful. And can you use the current data being collected through the Osteoarthritis Initiative study to look at that, or would you need to plan a new study to look at those issues?
I think that we would have to plan a new study to look at those issues, primarily because This is an observational study, right? So we did not provide any recommendations to people.
Hmm.
And I think it is actually quite true that people who have less knee pain are more likely to walk and that sort of thing. So I can't really sort of speak to that. Um, but I do think that it is pertinent to know that around 70% of the people in the cohort did walk for exercise. So it's not like people are not walking generally. So it's probably one of our um, least I don't know, I guess there's fewer barriers into getting people to walk, and so I think people do walk. And the other thing is this, as you said at the beginning of our discussion today, it's already being recommended. We are already telling people to walk for exercise within the ACR guidelines for osteoarthritis management. We already say it. And then also, the CDC is also making that recommendation, and that is from the perspective of cardiovascular health and for reduction of incidence of diabetes and for a decreased risk for malignancies. And so, there's lots of reasons for that people should walk, and they're getting that recommendation anyway. And so, really, if I were to guess, I would think that there's also a risk for confounding by indication, right? So that people are walking because they've already been told that they have osteoarthritis,
Yeah,
and that
and they're in an osteoarthritis study, right?
yes,
So
exactly.
they're going to
So
be a little bit different in terms of
yeah,
how
so
they
it could
behave.
it could actually go either way, but what we can comment on is really just that this is what we saw. And
Yeah.
when people are sort of left to their own devices and they do what they want to do, irrespective of whatever the public health message is or what their doctor tells them, they seem to do better.
So I know we've talked a lot about your research and the data in this specific paper, and it's really clear that you're very committed to osteoarthritis research. I wonder whether you'd be willing to take a few minutes just to share with our listeners how you got your start in rheumatology and in OA research specifically.
Sure. So I got my start in rheumatology because I didn't like primary care. And when it was time for me to look for a job after I finished my residency, I thought, well, this is not something I want to do. So I really felt like I needed to go back to the drawing board and find an area that really spoke to me. And I sort of reflected back through my residency, and I really enjoyed my rheumatology elective. And so I applied to the program that was at the same institution where I did my residency, which is at Boston University. And fortunately, it was a very good program, and it still is. And they also had a T32 program at the time where they funded people who were interested in doing research. And since I realized at the end of my residency that I didn't want to go out and do primary care, I kind of I didn't want to put all my eggs in one basket. And so I just felt like, okay, there's this opportunity to get a master's of science in epidemiology and to explore the whole research aspect. And it was just seemed like a win-win to me, and so that's how I got my start. And I started working with this large group of people or investigators at Boston University who are very well known in osteoarthritis research. So David Felsen was my first mentor, and then after that, Tim McLendon, who I've really collaborated mostly with since then. Um, he was there, and then that's how we began working together. And then David Hunter, I've worked with quite a bit, and so I would say that Tim and David Hunter are two people who I really look up to as far as research that they have done in osteoarthritis, and they've really shown me how important it is to do research in this area and how much of an impact we can make. And so that's how I got my start.
Yeah, and I think that's a great story actually for our trainee listeners to hear is that your fellowship really is a time where you can try a few things with a freedom to fail, right? So
That's
try
right.
out things that you may love or that may not be a good fit for you, and you don't know until you try them. And I really feel like that's actually the best time to give your kind of research opportunities a try. And you obviously had a phenomenal opportunity at Boston University, some real greats of osteoarthritis research,
Yeah.
obviously, at that institution. So it sounds like it kind of launched you onto this pathway. You're now obviously sort of now in mid career, have been very successful. Do you have any advice for our listeners who are earlier in the physician scientist pathway?
Um, so I guess I would say if you're even a little bit interested, give it a try. I think do a project with somebody who is established in doing research. I think that when people try to wing it and just create their own study, I don't think that that's a good avenue. I think trying to shadow somebody who is very established or at least working hard on finding that pathway, I think that's sort of the way to go. And I think that you can't just give it a try for like 1 or 2 months. You really have to give it like a proper try. You have to try for a few years and then see how it works out. um, I remember actually having a conversation with David Hunter, and I said, "Well, I'll try for a year and see what happens." And he kind of chuckled and he said, "You're not going to know anything at the end of the year."
Particularly not in osteoarthritis research, right?
No, yeah, and I think his advice was correct in that you can have one success and then one failure and one success, but you shouldn't make your decision on what direction you want your career to go in just based on one success or failure. I think that you have to look at the overall picture. Do you enjoy going to work? Do you like the work that you're doing? And I think that really helps to help you make that decision of,
Yeah, no,
is
you
this
have
a
to
right
like your
fit for
work
me or not?
even when it fails if you're
Yeah.
going to be a scientist.
That's right.
And so finally, I can't possibly let you leave without actually asking, are you yourself a walker? And do you have any tips on motivating yourself or your patients to walk?
So I have to say that, much like you, I have to say that the study made me go out and walk more. I mean, in general, I would say that I have walked most of my life, because it's an activity that you can do anywhere, and there's very few barriers to it. You don't have to pay any kind of membership fee in order to go out and walk. And so I definitely have started walking more, especially now that I'm getting older and now that I'm quote mid-career. I guess I'm mid-career in my life too, so so I do want to do things that will help protect my joints and keep me healthy, and besides uh, decreasing my risk for osteoarthritis, or at least becoming symptomatic from osteoarthritis, I think it also has so many other health benefits, including what we mentioned, or what I mentioned before, cardiovascular health and decreased risk for diabetes and for cancer prevention. It's like a win-win. I mean, I have to say my mom actually has hand osteoarthritis pretty obviously, and so it's made me very worried since I was able to diagnose her. And she also has knee osteoarthritis, and so and there's definitely a heritability to osteoarthritis. So it definitely has motivated me to work on things that I think will help from a preventative perspective.
So now that you're mid-career but have enough still lead time to go in your career, maybe you should do that study where you look at children from people with established OA, children who are now adults, right? And see if an exercise intervention alters.
So
Uh,
it's actually, I don't know if you actually you said that because you know about a prior study that I've done, but
I didn't know.
I
Share.
actually, so yeah, so there's a study that I did looking at the offspring of people within the osteoarthritis initiative. So we did it was like a pilot study where we are trying to see if we could actually find a way to interact with these people and that they would engage with us, right? So the people within the osteoarthritis initiative, in total, there are 5,000 people. But when they started the study, which was around 2004 to 2006, the mean age was 63. So by now they're all in their 80s or 90s. And so we wanted to find a way to actually capture the people who are younger, who are also at risk. And so it seemed like a good idea as far as a way to learn to study these people. And so we were successful in the way that we took one clinical site where we tried to implement this at University of Pittsburgh, and we were able to show that medial compartment osteoarthritis is heritable, and what we found is that people who have radiographic evidence of medial compartment OA in both knees, their kids are much more likely to also have the same. And so this is, a great find as far as a way to maybe allow the osteoarthritis to continue on. So we are going to try and put something together to look at this group of people. Um, actually,
Yeah, that's fabulous to hear, because
yeah,
that's the real need, right? That's where the future of osteoarthritis will lie.
yeah, yeah. So if I mean, it was kind of like a harebrained idea of mine, and so it'd be nice if it works out if we're able to deploy this methodology across all of the clinical sites for the osteoarthritis initiative, and if we can, find a way to deploy an intervention. So
That would be fabulous. So that's really exciting. And Grace, thank you for joining us today. I've really enjoyed talking to you. I appreciate all the time you took to join us today. And just want to thank you for doing this work. I know that sometimes it feels like you're toiling and these long lead times in osteoarthritis, but just know that these studies do make a difference.
oh, well, thank you very much for having me and for allowing me to talk about our study. We're very excited about it, and thank you for allowing us to share our findings with the audience of your podcast.
Thank you. So, I want to conclude our episode today by giving a shout out to the ACR staff. The American College of Rheumatology has a mission to empower rheumatologists to excel in their specialty, and they're one of the few professional organizations who truly succeeds in their mission. COVID brought a lot of change for us all, with social distancing and this strange feeling of being a little bit disconnected from our communities. And it seems that that's persisted even now that we're interacting more freely. But I like to think that despite all the challenges the last few years brought, our college is and will continue to be the social glue that binds us together. They work behind the scenes to advocate for our patients. They work in very tangible ways to educate rheumatologists, both in the US and around the world. And they make our lives better as rheumatologists. Thank you to the ACR and ACR staff for everything that you do to support the practice of rheumatology. Thank you all for listening to this show. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media, and please rate and subscribe to our podcast at acronair.org or wherever you get your podcasts.